Thank you very much. It's a real pleasure to be here. I have been to a AGM once before in the past, but it's very nice to see lots of familiar faces still involved in COMP. So I was asked to kind of give some information and perhaps a bit of a lecture on the whole issue of comparing the NHS with other healthcare systems, and in particular to talk a bit about the way in which some people keep talking about how the European healthcare systems are better than our tax-funded NHS here in the UK, and should we be moving in that direction. So that's what I'm going to do. I'd like to first of all acknowledge my colleague Ilias Kondilis, who's helped me to prepare this presentation. And what I propose to do is to, first of all, I'm going to be quite academic. So just a warning, I'm going to talk as though I'm providing an academic lecture about comparisons of health systems between countries. But what I wanted to do is really start off with introductory comments about first premises and the importance of being clear about your normative position and principles when it comes to analysing and discussing and debating different kinds of healthcare systems. I then want to describe, provide a couple of frameworks, because healthcare systems are complex, I think frameworks are important if we want to study and assess things like the efficiency and effectiveness of the healthcare system. So I want to provide some kind of academic framing to how we go about assessing the performance of a healthcare system. I then want to provide some data that actually shows comparisons between the NHS and other healthcare systems, and then end with a couple of conclusions. So my first premise is to make a rather obvious point, which is the fact that the NHS of today is not the NHS of the past. And there have been huge changes in the NHS, particularly in terms of the degree of marketisation, the degree of changes in the ownership of healthcare facilities and on the provider side of the healthcare system. And there's been big changes in terms of the culture and ethos of the health system, both in terms of patients and the general public, but also in terms of healthcare providers. So when it comes to comparing the NHS with other healthcare systems, we have to be careful. There's a real issue about framing. Are we comparing the NHS as it currently is, or are we comparing and talking about the NHS as it was originally conceived? A really important point, I think. The second premise that I want to kind of talk about is the fact that health systems are there to deliver healthcare services, often to individuals, but in addition to individuals, services to populations. But healthcare systems provide a whole bunch of other functions. Healthcare systems are in fact also social, political, cultural and economic institutions, and as a result they also have a range of social, cultural, economic and political functions. So again, when it comes to assessing the performance of a healthcare system, we need to be thinking about what we are assessing that performance against. What are the objectives and functions and purposes of a healthcare system? And this often gets lost in discussions about the performance of the NHS. Just by way of example, healthcare systems provide a really important function, a social function, a cultural function in terms of shaping and mediating these profound human experiences of giving birth, of aging, and of dying. That's a really important social and cultural function. And to some extent, people will talk about the NHS actually controlling that experience of birth and aging and dying. People talk about the NHS having over-medicalised aspects of human life in a way that hasn't perhaps necessarily been so positive. Clearly, healthcare systems are important in influencing the financial consequences of illness, injury and disability. In the US, healthcare costs are one of the biggest causes of household bankruptcy. And of course, being sick, being old, being infirm is to be vulnerable. We go back to the origins of the NHS. Bevan did not talk about a health system that would be effective and efficient. He talked about a health system that would provide freedom from fear for people. That was a strapline for the birth of the NHS. Freedom from not just the fear of illness, but also from the fear of the cost of illness. And it shapes and reflects a whole bunch of societal norms, values and relations. It tells us about the role of the state in society. It's an expression of human rights in society. And it shapes the relationship within society between rich and poor, between young and old, between those who are sick and those who are well, and also between one place in a country and another place. So these are all really important social, political and cultural functions of a health system that are important to consider when we assess the performance of a health system. Needless to say, a healthcare system is also a system that expresses a political ideology. I mean, interesting, when Obama tried to reform the healthcare system in the US, he was called simultaneously a Nazi and a socialist at the same time. Yeah, and I guess what we see in the NHS is really a battle of ideological principles and neoliberals. When talking about healthcare reform, we'll be emphasising the importance in society of having a small state, not just for the healthcare system, but because they believe that society is best organised in a way. Society is best organised when the state is small. And of course, neoliberals will promote the market out of principle, out of ideology, partly in the belief that this will promote efficiency, but partly out of a kind of political ideology. Healthcare systems also are economic institutions. They provide an economic function. This is a famous report that was produced by WHO. Lead author was Jeffrey Sachs, who made the argument that healthcare systems have an important economic function in terms of helping to provide for a healthy population was to provide for a healthy economy. People like David Stuckler and Sanjay Basu, I think some of you may have read their recent publication, The Body Economic, talking about the different responses to the financial crisis of 2008 and making the argument that healthcare expenditure is a fiscal multiplier, that it is not a cost to the economy, but it can be, in certain circumstances, a way of growing the economy. And helping the economy come out of recession. The NHS is a big source of employment, a big source of jobs. So when we assess the performance of the NHS, do we consider its function as a source of employment? And what impact that employment will have on economic indicators? We also see a government currently that sees the NHS as being a source of exports. It's really an export industry in the minds of certain people in government. It's a mechanism by which we again grow the economy through a whole range of exports that will be grown out of the NHS. So clearly the NHS is more than just a place, a health system is more than just a place for delivering healthcare services. It's also got an important economic function, and it is a market. And in the US, of course, there's plenty of evidence of it being a lucrative market for certain economic actors. There's a health economist called Bob Evans, who's from Canada, who I try and get all my students to read. And he makes a very, very important point. which is if you want to understand debates about healthcare reform or health policy, as with many other contemporary aspects of society, you need to follow the money. And Bob Evans produces a very simple equation in some of his textbooks and teachings. And that's the equation R equals E equals I. R is revenue. You need to raise money to pay for a healthcare system. Where does the money come from? It can come from taxes, can come from out-of-pocket payments, comes from insurance premiums. In low-income countries, some of the money for a healthcare system will come from loans or international aid. That's R. R is turned into expenditure, E. So we raise money and then we spend it in the healthcare system. We spend it on personnel, we spend it on drugs, we spend it on buildings, we spend it on IT systems, on management. If you're in America, you spend a large amount of R on advertising. That's expenditure. But for everything we spend in the healthcare system, that then gets translated into someone's income. Income in the form of wages of doctors and nurses, wages of managers, wages of lawyers and accountants who take a big chunk of E in the US, for example, shareholders, builders of hospitals, clinics, software engineers. So R equals E equals I. That's the way the money flows through a healthcare system. You raise it, you spend it, someone is always making money from that expenditure. Very often, we spend a lot of our time discussing R and E. Where does the money come from? What should we spend it on? Very rarely do we actually consider I. Where is that money flowing? And Bob Evans makes the point that most debates around healthcare policy tend to be about R and E overtly, but in actual fact, what they are is about I. It's about where the money flows in terms of income. So he will, for example, make the point that for people who work in the healthcare system, we have a vested interest in wanting to maximize R. We want to grow as much revenue for the healthcare system in order to grow the level of expenditure, because we benefit, because we earn from that expenditure. So there is a vested interest, in fact, in amongst healthcare professionals and people working in the healthcare industry to maximize R. And you can see that in the US, where the percentage of healthcare expenditure as a proportion of GDP is very high. There are very strong political lobbyists in the healthcare insurance industry, in the pharmaceutical industry, who have managed successfully to grow the amount of R so that they can increase and maximize their income. But we can also see that there is competition about how income is distributed within the healthcare system. Competition between doctors and nurses for a share of expenditure. The pharmaceutical companies want to maximize expenditure on pharmaceuticals in order to maximize their income from healthcare expenditure. So on and so forth. So this is really where the politics of healthcare policy is best understood. It's understanding not so much what we spend money on, but how that expenditure is translated into income. So I guess the first point I wanted to make is that if we want to start thinking about how we assess the performance of a health system and how we compare our healthcare system with the healthcare system of another country, we've got to be, first of all, clear about what is it that we want the health system to do. What are the primary functions that we value in a healthcare system? Is it simply to be an efficient deliverer of healthcare services? Or is it also to have a particular social function in society? What should be its economic function in society? How much value do we place on it being a source of employment within society? And how do we have trade-offs in terms of these different functions that a healthcare system might play. It's interesting when we hear the NHS being talked about in the mainstream press. It's often described as being the nearest thing to a national religion that we've got in this country. And that kind of suggests that we all have a shared doctrine about what the NHS is. In actual fact, I think that the NHS is really a battleground for competing ideologies, values and beliefs. Not really a shared religion, more of a battleground for competing ideas. Okay, so healthcare systems are complex. They have different functions. They produce different outputs. And so if, again, we want to try and assess and understand the performance of a healthcare system, it's useful to have frameworks. And I want to start by this framework, which was produced by the World Health Organization in the year 2000. And this was the first time that anybody attempted to create some kind of metric in order to be able to compare health systems from one country to another. In the year 2000, WHO produced a ranking of all the healthcare systems in the world according to their performance. And the way in which they did that was to, can you see this? Yeah, was to look at 4 functions of a healthcare system and to measure those functions in terms of a set of different objectives for the health system. The functions were, first of all, a health system needs to be able to provide stewardship. Can you see this? Yeah. Provide stewardship, and that would include policy, regulation, monitoring and evaluation of the entire health system. It would need to create the resources to enable a healthcare system to deliver services. And those services would be both personal services and non-personal services. And importantly, to create the financing to enable those resources to be created and to enable the delivery of services. So that's how WHO conceptualized the functions of a health system. In terms of the purpose of the health system, the objectives of the health system, it was obviously to improve health. It was, secondly, to ensure that there was a fair financial contribution, so that the people paying for the healthcare system were paying for the healthcare system in the way that was deemed to be fair. And thirdly, to ensure that the healthcare system was responsive to the wants, desires and needs of people. There was more of a social and cultural function of the healthcare system. This is that same framework, but here you can see in this circle an unpacking of how you might assess the provision of services by a healthcare system. So beginning to look at dimensions such as equity, access to healthcare, quality of healthcare, the efficiency of providing those services, and the sustainability of the health system in being able to deliver those services. So what I'm trying to show here is that if we want to assess the performance or measure or evaluate the performance of a healthcare system, it's quite complicated. There are many different dimensions to a healthcare system, and when we talk about performance, again, there are many different dimensions or aspects of performance that we might want to think about and measure and evaluate. There are also trade-offs between these different dimensions. So there may be a trade-off between efficiency and equity. There may be a trade-off between ensuring universal access and the issue of quality across the healthcare system. So how you measure the performance of a healthcare system will be strongly influenced by what you value in terms of these different dimensions of performance and quality. This again is another framework. Here you can see an emphasis on the healthcare financing system. These are the intermediate objectives of the healthcare system, looking at quality, equity, efficiency. This is interesting. It didn't appear in the earlier slide. The issue of transparency and accountability. Is that an important dimension for a healthcare system? Should it be transparent and accountable, or should it only be effective and efficient? If it is important, how do we measure it? And how important is it relative to efficiency and effectiveness? And then in the right-hand column, you've got the health system's goals, and this has been unpacked a little bit more compared to the earlier framework. So you've got health gain. How well does it perform in terms of health improvement? Equity in health. We're not just interested in aggregated health improvement, but also in equitable healthcare outcomes. Thirdly, there's financial protection, that issue about freedom from fear, the issue of being able to protect yourself against the cost of illness. How well does the health system perform in that regard? Then we've got equity in finance, and then responsiveness. So again, measuring the performance of a healthcare system is complex, many different dimensions to consider. The issue of healthcare financing, of course, is very critical. We've talked earlier about, or I heard you discuss earlier about the importance of public financing and of a progressive tax-based system. And this is the reason why it's so important. This is a core fundamental issue of any healthcare system, is being able to pool the financing for a healthcare system in order to enable two functions to occur. One is a sharing of the risk of illness and disease, so that we can share the cost of illness and disease between those who are young and healthy and those who may be unwell and more elderly. That's called risk sharing. And then there's the issue of cross-subsidization, being able to transfer financing from those who are rich to those who are less wealthy. And the only way you can do this is by pooling the financing, sharing the financing of a healthcare system across the population. And WHO and a lot of the academic evidence will suggest that in order to maximize the impact of financial protection and cross-subsidization, you should have a single national pool. That is WHO's recommendation as being the best way for creating a pooled system of financing to enable progressive financing to maximize financial protection. But also there are strong arguments that national pooling will also enable better planning, economies of scale, and better cost control within the healthcare system as a result of creating what's called monopsony power, purchasing power, if you like, at the national level. There are different ways in which healthcare financing systems are categorized or classified, including big issues between the distinction between public finance and private finance. And here you can see where some of the debates have been occurring more recently between a taxation-based system, which is what we have here in the UK, and a social insurance system, which is more common in parts of Europe. Is this all right, or is this too academic? I hope this is useful. I'm rushing through this. I would normally spend 2 or 3 lectures explaining all of this to my students, so you're getting a condensed version. Okay, this is my last framework that I'm going to show, and possibly the most important framework. And what I wanted to show and highlight with this framework is firstly this relationship between 3 groups of actors in the in any health system. So that's the group of people, us, the population, patients, financing agents, and service providers. Okay? Population and patients, that's us. We have a relationship with financing agents in the sense that we provide money in the form of either insurance premiums or taxes to a financing agent that will then provide insurance coverage to us, to the population. This could be a private insurance company, or it could be a state insurance company, or it could just be the government, like we have here in the UK. There's a relationship between the people and financing agents. Money goes this way, and coverage for healthcare goes in the opposite direction. Financing agents also have a relationship with service providers. We pay money to service providers. Service providers, in this diagram, will provide claims to the financing agent for having provided health services to the population or to the patients. So you can see this kind of three-way relationship between these three groups. And these relationships are really important. The nature of the relationships between the population and the financing agents is really important in terms of determining your rights, your entitlements, in terms of determining the extent to which the healthcare system is progressively financed, the extent to which you have financial protection from the costs of illness, but also the relationship between financing agents and the service providers is really important. The extent to which it is marketized, for example, the relationship between purchaser and provider, or I put here purchasing or resource allocation. So in the NHS today, we have a relationship between purchaser and provider, which is very different from the NHS of the past, where we didn't purchase services from service providers, but what we did was to give them a budget. We handed them over a budget in order to be able to provide healthcare to a given population. So that relationship has changed considerably. And of course, the relationship between service providers and the population is also important. Is there a direct relationship, or is it a relationship that has to be mediated through the financing agent? And the relationship is also determined by a whole bunch of social and cultural factors. Do service providers see their patients as patients, or do they see them as clients and customers? Do they see them as people with an illness, or do they see them as people that may threaten their profit margin at the end of the financial year? So these relationships between these three groups of actors within the health system, the nature of the relationship, is very important in how the health system actually functions. Finally, a very big circle here is about the critical and important role of the government. Now, the government is here to regulate, provide stewardship over the entire healthcare system, but of course the government may also be in this box and in that box, where the service provider box. Public providers and public financing agents. So very quickly I come now to the distinction between tax-based systems and social health insurance. Tax-based systems are often called beverage-type healthcare systems, and the social health insurance systems are often given the moniker of being Bismarckian. What's the difference? In fact, there are more commonalities than there are differences, in my viewpoint. The commonalities is that they are both tend to be public and socialized forms of financing. The key point here is that there is mandatory financing. You have to put money into a pool. They are both progressive, provided that the tax system is progressive and that your social health insurance contributions are progressive. So social health insurance contributions tend to be made as a proportion of your wage packet. And they both allow for, as I said earlier, pooling and monopsony power. But there are also differences. There are differences in the degree of progressivity, the degree to which the financing is progressive. And by and large, social health insurance systems tend to be less progressive than tax-based systems, because the financing mechanism is different. They tend to be caps placed in social health insurance systems on the wealthy, so that the proportion of their income that is contributed into the pool tends to be less than in a tax-based system. Many socialized health insurance systems also allow for the very wealthy to opt out of their system. So generally speaking, they tend to be less progressive. They tend to be less public in general, as the degree of publicness is different between European systems and the UK-based health system, for example. The degree of financial protection tends to be less with social health insurance systems. The degree of universality and the degree of predictability about the budget that will be spent can vary between the two types of systems. So there are minor differences between the European-style health system and the tax-based UK healthcare system. So coming back, I mentioned earlier that WHO provided a ranking of all healthcare systems in the year 2000 using their particular formula for how you assess performance. But you're probably quite familiar with this other ranking exercise that's done by the Commonwealth Fund based in the US that has consistently placed the UK as being the best ranked performer across a number of different countries. And they break down their ranking. It's a composite index based on a number of different kind of dimensions of performance. UK is still number 1, Australia is number 2. But if you look at the UK rankings, you'll see it scores 1 on the care process, 3 on access, 3 on administrative efficiency, 1 on equity, and it scores quite poorly on healthcare outcomes. But when pulled together, it comes out as number 1. How they measure all of this, what the indicators are, it's a bit of a black box, and obviously it could be contested. It's the way in which these performance measures are actually calculated. This is where it scores poorly, according to this Commonwealth Fund report. This is the mortality deemed to be amenable to healthcare. And you can see here that the UK has relatively high mortality rates. So these are mortality rates that are deemed to be relatively preventable from the provision of good healthcare provision. However, what I want to highlight is some key messages from this report that was produced, I think it was produced about 6 or 7 years ago, a policy summary about the whole issue of health system performance comparison. And it made a number of really important points. The first, I think, important point is to say that in order to be able to draw meaningful comparisons, understand the drivers of differences in measures between systems, you have to adjust for variations in demography, social, cultural, and economic circumstances. You have to be able to adjust for that. It is very difficult to also create a numeric measure for social, cultural, and economic circumstances, which means it's actually difficult to provide a kind of metric that will allow you to compare one country against another. Single number measures of whole systems performance, while offering a more rounded view of performance, actually have limited scope in terms of helping to inform policy debate about how to improve the functioning of a healthcare system. All population health indicators suffer from a number of methodological problems, which hinder meaningful international comparisons. Direct indicators of the contribution of health services to health status are available in the form of health service quality measures, such as standardized hospital mortality rates or disease-specific mortality rates. So we've got reasonably good information about that, particularly in high-income countries, and particularly in Europe. However, far less available are measures of the impact of a health system on morbidity and well-being. International comparisons of health service measures are complicated by different organizational settings and reporting conventions. So the way you measure things, the way you collect data varies from one country to another and makes it difficult, again, to provide comparisons across countries. It also goes on to say that comparative indicators of health inequality and equity in access to healthcare may be misleading due to limitations in the availability and comparability of data. Indicators of financial protection have proved difficult. In terms of being able to develop a single indicator to capture the full extent to which people are financially protected from health shocks. There's a lack of clarity as to what dimensions should be included in the domain of responsiveness, which embraces concepts such as respect, confidentiality, and prompt attention. And in measuring efficiency, this is a word that we hear often in the press and talked about by politicians, there's a fundamental challenge in the assignment of inputs and associated costs to specific health systems activities, and we often rely on arbitrary accounting rules or other questionable assignments. So there's a big health warning to be attached to measures of performance and indicators of performance, and in particular to the use of those indicators to compare performance of one health system against another. Nonetheless, I'm not saying that we shouldn't attempt to measure the performance of our health system or to compare them with the performance of the health system in other countries, but we just have to be careful in how we do it and how we interpret the data. This is some data on health financing, because this again is consuming a lot of media attention and public debate. Here you can see percentage of GDP that is spent on healthcare. And of course, all of you know about the US being an outlier. A huge proportion of GDP is spent on healthcare. This blue line here is the UK. This orangey line here is the OECD average. So we are roughly at the OECD average for proportion of GDP spent on healthcare. You'll see this big jump here. There's a big sudden jump. What was the result? What was the cause of that?
Redefining social care.
Yeah, it was change in the definition. It was change in the way in which data was collected. And a lot of social care expenditure that had previously not been included in healthcare expenditure was added at that point in time. So for a long time there was a view that we were, not spending as much money on healthcare as many other European countries. When that adjustment was made in 2011, that difference became much less marked. This is the right one, blue. We're blue on this graph. UK is blue on this graph. You can see again the jump though at that period of time. And this does still show that compared to some European countries, we spend a lower proportion of GDP on healthcare. Yeah, considerably less than Switzerland, for example, which is particularly high, less than France, and less than Germany, less than Norway. This is a proportion of GDP, and this is the graph looking at it in terms of per capita healthcare expenditure. All calculated in euros and adjusting for purchasing power. And here you can see that the UK does spend less per head on healthcare. This is an important graph. This is a graph looking at the KONP index, and this is an index of progressivity of financing, the extent to which people of higher wealth provide a higher proportion of their income into the national pool for financing of healthcare. And anything that is more than zero means that the financing system is progressive. Anything less than zero is that it's regressive. So regressive would mean that poorer people would pay a higher proportion of their income for healthcare than richer people. Richer people may still pay more in dollar terms, but we're talking about them paying less as a proportion of their income. So the US and Switzerland are the most regressive of this list of countries. But what's interesting is that the most regressive of these countries are also countries which have very high levels of healthcare expenditure. The UK is quite progressive compared to some of the other countries that are also progressive. But what's interesting is that the UK, Italy, and Finland are tax-based systems. However, so is Portugal. But that turned out to be tax-based and regressive. So how the tax system is structured can have a profound impact on whether the healthcare financing system is progressive or regressive. Germany and France are social health insurance systems. What's interesting that Germany is regressive and France is progressive. So it comes back to this point that, that there are often more commonalities between social health insurance systems and tax-based systems, but how they are designed, the detail of the design of those systems can have a profound impact. I'm sure you've all seen this graph, that in high-income countries, the relationship between the amount we spend on healthcare and life expectancy has broken down. There seems to be no relationship, no correlation between the amount we spend on healthcare and our average life expectancy. Again, the reasons for this is that there are many other determinants of health. And as for those of you who've read the book written by Kate Pickett and Richard Wilkinson, they contend that what's critical is not so much the level of healthcare expenditure that's important, or the average level of economic development, but rather the degree of inequality within societies that profoundly, that does have a strong correlation with average life expectancy. Okay, this is a very complicated slide that my colleague Ilias produced, looking at measures of catastrophic health expenditure and how it relates to tax-based systems versus systems that are based on social health insurance. And the reason why this is important is that there are some people who are advocating us moving towards an insurance system rather than a tax-based system. And there are lots of different reasons for that. But certainly I think private finance and private capital and private companies are keen for us to move towards an insurance system. And were we to move towards a social insurance system, that would certainly be a stepping stone towards opening up the door towards more private healthcare insurance schemes. And so it's really important to get the argument about the benefits between social health insurance versus tax-based healthcare systems right. And there has been some data, some analysis that was recently produced which suggests that tax-based systems do not necessarily offer better protection from CHE, which is catastrophic health expenditure, compared to social health insurance. Okay, conclusions. Comparisons are difficult. It's very easy to cherry-pick indicators to fit just about any argument that you want to put forward about policy. Ideological and normative positions need to come first. We need to define what kind of healthcare system we want and what we want it to achieve for society. Then it's a case of using theory to guide policy. Once we've defined and decide what is it that we want the health system to achieve, socially, economically, culturally, then there's a whole bunch of theory that we can use to inform the best way in which we should then structure and organize that healthcare system. Then it's a case of implementing the policy well. And there are many countries where we have good policy but bad implementation. That doesn't make the policy bad, just makes the implementation of good policy the problem. But of course, as with anything, there's the small issue of also having to counter the prevailing neoliberal ideology, which talks up the importance of choice and competition, and of course the propaganda of private capital. And I just want to very briefly go back to that Bob Evans graph, but I forgot to mention the fact that in red here, private capital is often missed out in any analysis of healthcare financing and healthcare expenditure. This is where a lot of the problem is, that there is a lot of private capital that is seeking to break into the socialised health systems of the UK and Europe, and having a massive influence on healthcare policy. And that private capital is, of course, spending quite a large amount of money promoting the idea that the NHS is not sustainable, that the demographic pressures on the NHS require us to make fundamental and radical changes to the financing system, etc., etc., etc. That is coming largely from this group of actors in society. Good, thank you. I hope that was helpful.